All right, thank you all for coming today. We're going to go and get started. As most of you know by now, we've been to these things. My name is Wes Kaufman. I'm one of the managing partners at Heartwood. Again, very excited to have everybody here today. Should be a really interesting topic. I've gotten a little preview, and I think you guys will very much enjoy it. We're lucky enough to have Dr. Vaughan with us today. He's a Richmond, Virginia native.
That's right.
W&L grad, did his medical at VCU, then did a residency up at University of Maryland in Baltimore, right? And came back here to do an infectious disease fellowship at VCU, which turned out to be, fortunately or unfortunately, pretty good field to go into, because then we had a little thing in 2020 happen. Dr. Vaughan really became, in a lot of respects, sort of an expert in the community about strategies to mitigate and what do we do about COVID-19, and worked with a lot of hospitals and schools, and I'm sure he'll talk a little bit about that. And he's currently the medical director for Clinical Research Partners, and is working on a lot of clinical trials for severe COVID and also for other infectious diseases that, as he says, keep infectious disease specialists up at night and worried about. So he's going to talk to us about all that stuff. So without any further ado, it's all yours.
Thanks, Wes.
Yep.
I'm super excited to be with you all. I had a little bit of wonders. Like I've never spoken to a group of investors, so to speak, and I've never come into this forum before. But one of the things I'm hoping to do as an infectious disease physician, there was quite a lot of consternation about kind of from whence we came, this pandemic. And I think opening lines of communication offer opportunities for you all to ask questions of me, see how I see things as the dust settled. I'm not going to talk a ton about COVID in the slides, but I'm going to talk about a number of pandemics. I'm going to talk about a number of different kind of interventions and strategies we have to mitigate the risk of future pandemics, and how did we do it in the past. And my hope is that you all will feel comfortable just interrupting and asking questions. This is a seminar. I went to Washington Lee University. A lot of those classes were seminars, so you could kind of tactfully raise your hand, or you don't have to raise your hand, but signal to me that we have a question, and we just have a conversation. I think the conversations are good. I've had the opportunity of giving discussions and talks to schools of teachers during the pandemic and parents. So you can imagine the firing squads that I've been before, me making sense of imperfect information and trying to conceptualize and package it in a way that is delivered to people, and a way that treats that person with respect, and hopefully that's reciprocated. But anyway, we'll talk about this. So the title of the talk is Outbreak, a Century of Pandemics and Humanity's Progress in Dealing with Them. I do sit on the Virginia Board of Medicine. It's pretty much a regulatory board where I make sure that people do the right thing with their license and stuff like that. But I'm not going to be talking about that. I'm not speaking on behalf of the board at all. I'm speaking as a physician. I'm not your physician. I'm a physician. I do advocate for a couple different antibiotics, hopefully to keep people out of the hospital if I can. And some of the work that I do in phase 1, 2, 3 phase trials, as you can see here, government, little pharma, big pharma. And then finally, this is just educational. I'm not pitching anything, any company. I'm not pitching any drug. So this is just educational. So here are my objectives. History of pandemics. We'll go through a handful of them. I'm going to talk a lot about the ones that I've experienced thus far. Our countermeasures to these pandemics. What weapons do we have? Pathogens that keep me up at night, as Wes had mentioned. There are a couple that I'm going to harp on. Flu and Mpox being a little taster there. And human psychology and its contribution to our pandemic vulnerability. So I think the psychology component, you guys are all investors too. Investor psychology, there's a lot of overlap of cognitive biases in investing, as well as what medical decision should I make. So and this is kind of a morbid slide, but I try to liven it up a little bit. That's my grandfather on your right side of the screen. His name is John Clark Twaddell. Is actually I knew him as John Clark, and I'll tell you why. And that's his older sister, Mary Jo Twaddell. In 1918, his parents, my great-grandparents, were living kind of in Philadelphia, or they were from the Philadelphia area. My great-grandmother contracted Spanish flu in 1918. And he also did. And I always noticed a scar on his back whenever I'd see him kind of swimming when I was a little kid. Never really understood to ask until later on. And back in 1918, she developed flu and she died. And their father, there were 3 siblings. The oldest is not in the picture. There are 3 siblings. This is obviously early 20th century. Their father, my great-grandfather, said, I can't take care of the youngest 2. I'm going to take the oldest, and I'm going to allow my sister-in-law, his wife's sister, surviving sister, to take these 2 kids. And they were taken under the wing of their aunt and their uncle, and their last name was Clark. And so they grew up as Clarks. I named my child Rosalie Clark Vaughan, kind of not knowing that Clark was kind of an inherited name. Thanks to the pandemic, they essentially took the name of their aunt and uncle. And Twaddell were actually Irish immigrants, kind of found this out kind of late in life. They all came from Coleraine, Ireland, not too long ago. But the pandemic of 1918 has touched my life, and it's crazy that I've had a couple I've had to deal with in my life. Anyway, so the scar on his back was he got horrible pneumonia. This is pre-antibiotic age. Most people actually died of bacterial pneumonia after you got the Spanish influenza. And they had to drain his lung, and because he had a big collection of fluid there, they drained it. And he somehow, without antibiotics, survived. And he passed away at 101. So he had some stories. And Mary Jo, my great aunt, she survived until her 90s. So 1918 was kind of a beacon that I look back in medical history. You can see here the masks that were conjured from gauze pads with tape. You can see throughout the nation. Back in 1918, World War I was brewing. Troops were kind of scattering all over the world. They call it Spanish flu. Does anyone know why they call it the Spanish flu? It probably didn't originate in Spain. Well, Spain was fairly neutral in World War I, and the news agencies didn't like to communicate that a lot of people were dying in their home countries of some mysterious illness. So they kept that under wraps, and Spain was the only one who was kind of reporting there is an influenza outbreak or some influenza-like illness outbreaking right now, and lots of young people are particularly dying. The thought is, no one really knows where it began, but the Spanish, because of their reporting, it got labeled as the epicenter of this pandemic, which is likely false. There are a lot of theories that it came from here. A lot of theories that it came from Kansas, where it was some of the first reported cases were on a military base in Kansas, where all of a sudden a handful of recruits who were very young, very healthy, started not only developing influenza, but pneumonia and dying. And that's not your typical group of people who die of flu. Usually they get better really quick after maybe a week, maybe 2 weeks. And so the chances are, so why did it emerge in Kansas? Typically you see influenza outbreaks when you see these big pandemic epicenters. You see it in places that are generally agricultural communities, where there are pigs, where there are birds being raised for agricultural purposes, and where there are humans. Why? Because influenza can readily go between those species. And as it jumps from species to species, it develops fitness and then can spread. Typically, and we'll talk a little bit about avian flu later. But did you have a question? Oh, I saw you raising your hand, sorry. So that is typically where you find these outbreaks occur. So 1918, 1919, you can see the death toll in America was 675,000 recorded in those 2 years, really 18 months, and infected over 50 million people, and over 500 million people infected, and 50 million of them died. As you guys know, reporting isn't great. COVID pandemic it's always hard to report things accurately and timely in a way. We're back in the 1918. I'm sure there is some, with everything that I'm going to say today, there's always going to be a little bit of flux here. But you can see, compared to other flu pandemics, you can see the Spanish flu kind of takes the cake. When I was a resident at University of Maryland Medical Center, I was in the ICUs when 2009 happened. You guys remember the swine flu of 2009, likely emerged from Mexico. Similar situation. We have a big shift, what we call antigenic shift, like this virus changes from an H3N2 virus to an H1N1. Immunity has waned over the course of many years, if not decades, and all of a sudden you have this generally new virus. And what do you have there? I had ICUs filled with people who, some of which were young. I remember many of which were pregnant. Pregnant women are always a fairly at-risk group of people. And that was proved true during the pandemic and during COVID. So the Spanish influenza was a horrible, horrible time for much of us, and it still has impacts on people even like me. And flu is going to be something that we're going to continue to see.
Can I ask a question about the
of course.
swine flu? I remember having to get an inoculation for swine flu in the 70s, and then it didn't happen. Is that something you know about?
I've actually got some slides about the 1970s vaccine, because during that influenza outbreak of the 1970s, it was quite a bad year. I think it was 1976. And there's a lot of consternation. We'll talk a little bit about it, but the U.S. became a very litigious place and the pharmaceutical company that made it wanted indemnity because we're going to make this vaccine hastily to get this out in August, because flu season, that was when that outbreak happened. Same thing in 2009, it happened in August. It usually happens in January-ish when we start seeing these spikes. We'll talk a little bit more about it, but all of the mess that comes with a vaccine that comes to market quickly, we've seen before. I pulled this graphic from an Alaskan periodical. This ran up to March of 2020. And it breaks down the mortality of the pandemics that we've seen thus far. You can see the bubonic plague has always killed quite a large amount of the European population. As you can see, 200 million people. But smallpox, particularly in this country, kind of decimated the Native American population because it was a brand new virus to that group, that group of people, of which there are many. And then obviously you see HIV/AIDS here, 25 to 35 million people. The HIV/AIDS kind of really started becoming prominent, and that was how I was introduced into infectious disease work, was HIV care. I quickly became the primary care doctor for all HIV positive patients in my clinic as a resident and fellow. And you can see that's quite a mortality rate, but it's been going on for 40 years now. And then as you can see, COVID-19 here only had 22,000 deaths. It probably falls into this area of 7 million around deaths worldwide compared to all of the rest. So this, as you can see here, we've seen quite a number of pandemics, and we've seen lots of different pathogens. I want you to take a step back. A lot of these are viruses, and so we've got to come up with some countermeasure to viruses. And I'm going to talk a little bit about that as we move forward. But since I've been in medicine, I was a med student when SARS-CoV-1 came out. Do you guys remember SARS-CoV-1? You probably remember there were people in Canada who were infected who traveled from China. There was a very famous Italian epidemiologist who noticed there was a novel pathogen that happened in Vietnam. That person, there was some travel from China, perhaps, that they knew that travel had to be shut down, that airline travel had to be shut down because this was causing pneumonia. This case fatality rate was quite high, meaning how many people died who get diagnosed as a definitive case. And the case fatality rate seemed to be in the 10% range. That's a very big case fatality rate. COVID is somewhere between 1 and 2. And this is almost 10 times worse. And so SARS-CoV-1 really kind of made us realize that coronaviruses are a potential horrible virus and quite transmissible, but can be contained with good epidemiologic interventions, good shutting down travel routes, and then you start seeing in China a lot of people wearing masks shortly thereafter. Influenza A, so I've talked a little bit about H1N1 swine flu. We did see that, and it was a time when a new vaccine kind of had to come to market quickly, and there was a little bit of a delay, I would say, in announcing a national emergency, and we had quite a number of deaths there. Middle Eastern respiratory syndrome, that didn't make a lot of news, but I will tell you, this is also was a novel coronavirus, likely thought zoonotic from a camel species from the Middle East. And this was our first time a coronavirus, in my knowledge, at least in my education, where the case fatality rate was 30 to 40%. So this is quite a pathologic virus. Also, this is where super spreader events were first noticed. Those people who were being cared for in the Middle Eastern hospitals, they noticed that there were some individuals that seemed to just spread it like wildfire, and other people did not. I think we all can remember, you heard about these super spreader events quite frequently throughout the pandemic, where you wouldn't see much spread, and all of a sudden there'd be one event and everybody got it. And so, interesting thing, Middle Eastern, this Middle Eastern or MERS actually did make its way to Korea, and Korea had a bunch of deaths, unfortunately, but it kind of went away as pandemics I would say, just vanish. I'll say Zika is something that I was very terrified that would spread even worse. Debatably, Zika came from potentially an athletic event in the Pacific or canoeing competitions where someone became ill after a bite from this mosquito that you see here. Zika is famous for causing kind of a febrile illness that can lead, particularly in pregnant women, to microcephaly of the baby. So pregnant women, particularly terrifying for them in the tropics. I can't tell you, during the 2015-2016 timeframe, I had a bunch of my friends who were getting married, hoping to go on honeymoons. And then guess what happened? They called me, they're like, should I even take this honeymoon? Because I can't afford having my wife and my new, potential baby that comes into the world. I don't want to, go on a trip that can be avoided or postponed. And so there's a lot of conversations about that. And then obviously SARS-CoV-2. I'm going to save that kind of a little bit for the end, because you guys are probably COVID fatigued, I would just say. But I'm going to open up the forum. Any questions about COVID, you can by all means ask. I want to talk about polio. Any of your parents talk to you about polio? I'm sure plenty. It was not a subtle disease.
When I was a child.
Yeah.
And our friends had it.
Yeah, I remember going to a camp called Camp Virginia, and the prior owners, Malcolm U. Pitt Sr. and Mrs. Pitt would have polio kind of outbreaks at camp, and by and large, it's just a febrile illness. You might get a sore throat, might have a little fever, and then you get better. But 1 out of 200 people can go on to develop irreversible paralysis, and it's quite a terrifying disease. And here are the when particularly in the 50s, when they were getting upwards of 15,000 yearly paralysis cases, particularly in children, they would use these iron lungs, which would essentially allow the lungs to mechanically move when you drop the pressure to very low rates. And this is an irreversible situation. Yes?
In terms of the inoculation, aren't there people now, do we still vaccinate?
We do, as children,
okay,
yeah.
But now there's
So
controversy as to whether people want polio.
yeah, well, we're going to get into that. We're going to hopefully discuss kind of people's re-looking at and suspicion for the pediatric vaccine schedule. I'm not a pediatrician, I don't give any recommendations on that. I am exclusively with adults. But my hope is there's a lot of vaccine suspicion after COVID, obviously, and I want to unpackage what those suspicions are, how they're formulated. Talk about some of the vaccine injuries that have occurred, because I think that's important to not just brush those aside. But
polio. Vaccines for polio, didn't they kind of lessen or mitigate the after effects? I have a brother who had polio.
Yeah.
And he has walked with a limp the rest of his life.
Yeah.
Because of like age.
100%.
And there were different times where he was more susceptible to things like bronchitis or pneumonia that the rest of us weren't.
Yeah.
We all were exposed to the same virus in the household. And for him, it was a longer recovery. And
Yeah, and I don't know the extent of his neurologic injury. Clearly, he had a neurologic injury that may have affected, even subtly, his respiratory capacities in a way. But I will say this. So I'm a big proponent of the polio vaccine. There's polio vaccine. I think it's clear that we should be vaccinated against polio. We already have massive polio vaccine campaigns going on in Palestine right now, because wherever war-torn countries are, we see typhus come back, we see polio come back, we see these vaccine-preventable illnesses kind of re-emerge. And polio, Jonas Salk, one of the kind of most impressive Jewish American people who have really made such an incredible impact on the world writ large, particularly for this to develop the first vaccine. Probably heard of the March of Dimes trial, where a trial was done, a small trial was done. He was like, this vaccine is safe, it's effective, it's potent, famous kind of quotes. We need to get this out there now. Why? Because we're having kind of 15,000 cases of paralysis every decade. And not to mention all the other kind of neurologic injuries. And then they're like, we need a much larger trial. We want 1 million people in this trial. And remember, when we do early vaccine trials, there's a placebo-controlled arm, and then there's a investigational product arm where you get the polio vaccine, the trial drug. Well, the unfortunate thing when you have such a large cohort of people, the people who are in the placebo arm, it's blinded. They don't know what they got. And if they're going to do the trial appropriately, it's double blind. The doctor doesn't know, the patient doesn't know. And they're going to be susceptible to disease that you're hoping that you're going to prevent. And with polio, they had a number of kids who died who were in the placebo group to prove something that was kind of already known in a smaller trial. But they went through it. They showed that polio vaccine was indeed what Jonas Salk had said that it was. And you can see a drop-off of 15,000 cases of paralysis. In the next, you typically saw 100 cases perhaps per year in the 60s, and then down to 10, and then complete eradication. So this polio vaccine, there are pathogens out in the world waiting to engage with your immune system. Polio is one of them. And this one is kind of a terrifying disease. And when this infant paralysis kind of in the 50s, when we were seeing the worst cases of this, I will say one of the psychologic things that happens, you typically saw about 3,000 cases in America where people would die of polio. In the same year as tuberculosis was going around killing about 30,000 people, much more. Influenza, probably 60,000, I think was the record year. So it's really important to think about pandemics. A lot of times we have things killing us all the time and we kind of brush them aside. Amidst another pandemic that is hitting young people that attracts a lot of attention. During COVID, for instance, we had influenza rates drop through the floor. Nobody got flu during COVID. Why? Because everyone was separated, everyone was masking. Masking helps a lot more for a droplet influenza pathogen because it truly stays in a droplet. During COVID, we found out that it actually spreads a little bit further, likely more than 6 feet. And we found that out. Large Cochrane review for masking basically said there was little to no effect with masking in kind of the public health as people walked around. It's a Cochrane review. You can look it up. Now in hospital settings, I'll say that's probably a little bit different. There are a lot of respirators, a lot of other kind of, the flow of a hospital is a lot different. But out in the grocery stores, out in the movie theaters, probably not the best intervention. However, influenza, it's much better. So food for thought. What happens at the beginning of a pandemic? There's panic. And I'll say one of the craziest things that I saw was that 72,000 cats were killed in New York. The SPCA just eliminated all animals because they were like, well, this could be a potential vector for polio. It's not a vector for polio. But this is what happens in the beginning of a pandemic. You guys know this. There's a lot of theories. There's a lot of misinformation. There's a lot of stuff that gets spread that likely needs to be validated. So you will hear kind of a trend. I don't want our culture to move into a place where we are so suspicious of just everything and cynical towards everything that vaccines are kind of cast aside. Vaccines have saved so many lives. And I think we've got to be a people to look at that. And so let's look at vaccines, and then I'm going to get into antivirals and monoclonal antibodies. But let's look at the morbidity and mortality before we had vaccines, and let's run down the list of diseases that we see vaccine preventable illnesses kind of on a timeline. This is a noisy slide, but I'll cast your attention to here. This is looking at the estimated annual average of hospitalizations and deaths for these diseases below. So hepatitis A, annual average was about 6,000 hospitalizations, almost 7,000, and 137 deaths. Now we have a 2-dose vaccine series, highly effective. You can test the blood to see if you've got good titers, and there are a number of deaths. Hepatitis B, it affects us here. It affects IV drug abuse or abusing populations more. It also affects, it is a sexually transmitted disease, which people forget, but 230 deaths per year, 7,000 hospitalizations. Invasive Haemophilus influenza. We also, this is actually a disease. It's a bacteria that is commonly the cause of pneumonia, sinusitis, inner ear infections, very common actually. But it also caused meningitis in kids at pretty staggering amounts. And so you would see 1,000 deaths a year before we had a vaccine called the Hib vaccine. Now, unfortunately, they don't get it now because they get Haemophilus influenza B vaccine. But when kids do get it, or when adults get it, it is a non-typable, meaning not a B Haemophilus influenza. What does that mean? That's called selection pressure. When we get a vaccine that it targets this, the organism will change itself in a way over time to get around those protective antibodies. So that's the daunting thing, is we've got to keep up with the scientific exploration of finding new therapies and finding ways to where these bacteria and viruses are circumventing our most clever scientists, I'll say. Invasive pneumococcal disease is no slouch. It is a very pathogenic organism. It's the #1 cause of community-acquired pneumonia, #1 cause of inner ear infections as well. 6,500 deaths. Now you probably heard of Prevnar. Have you gotten your Prevnar shot? Have you gotten your pneumococcal shot if you're at the right age group? I mean, we are constantly, I'm not gonna say we have frequent touch points with pneumococcal vaccine. Why? Because it's such a deadly disease. And thankfully, we don't just see that quite as much. Now, and also causes meningitis. It's actually #1 cause of meningitis. Varicella. So everybody in the room likely has had chickenpox. I was of the last class of people who actually got chickenpox before the vaccine came out. And I will tell you, about 105 deaths yearly, but 10,000 hospitalizations per year. That's not a small amount. That's a tremendous amount. I can tell you it particularly hits pregnant women when they are exposed and they have low titers or haven't had it. That is a time when I actually have to give varicella immune globulin, which is passive immune. I have to give them antibodies that are already preformed to try to keep the pregnant woman from getting varicella. Why? Because varicella pneumonia is quite deadly, or meningitis, obviously. Let's look a little bit more in diphtheria, measles, mumps, pertussis. These are all vaccine preventable illnesses. As you can see, prior to vaccine, almost 2,000 diphtheria deaths, measles, about 440 deaths per year. And then you had mumps, which was a little less rare, but I mean a little more rare in terms of deaths. Mumps is does anybody get mumps here? You don't have to answer if you don't want. Mumps causes paratitis, and it causes orchitis. Orchitis is swelling of the sex organs of the individual. I'll take a vaccine to prevent that. Even though my risk of death is low, don't forget about there are other morbid conditions that you just don't want to have, and that avoiding it with a small dose of a mumps vaccine is worth it. Here are the polio numbers. I gave you, I'll skip over polio, but quite an impactful disease that needs to always be mitigated with vaccine as far as I'm concerned, and really needs to be pushed. A new polio pandemic would just be so devastating. Rubella, congenital rubella, every now and then we'll see that when patients have lost their titers. Smallpox, 29,000 cases per year, and then 330 deaths, and then tetanus. Tetanus, you can see, is, I'm not going to say it's uniformly fatal, but it's almost uniformly fatal. It's exceeding. Once you have tetanus, it's very hard, once the toxin is in your body, to actually stop it from happening, from kind of executing on its ultimate way in which it puts you in tetany, puts you in an absolutely stretched out state, and you no longer can breathe. So tetanus shots are very important every 10 years generally. If you don't know your tetanus vaccination, you should go get one. Anyway, so I wanted to talk about measles. This is the most recent CDC data on measles. I have not seen a case of measles in the United States. I've seen it in South Africa, in KwaZulu-Natal, which is the eastern coast, or just inside the eastern coast of South Africa. And it is a very toxic looking individual with a floridly just, this patient was an African child, so had a much darker brown kind of macular rash, and typically very red. This patient is quite ill, usually has conjunctivitis, can develop meningitis and pneumonia. And as you can see here, the rates of measles is coming back up. Though it is small, with kind of more suspicion of measles vaccines, these pathogens are kind of waiting in the wings to kind of find hosts. I'm not going to personify them. They're not like chasing you around the corner per se, but when immunity comes down, you will see some of these. This is the most contagious virus there is. We have a way in which we grade something's infectivity or the degree to which it will infect hosts in a room. For instance, and we call it the row knot. And row knot basically says, in a room full of people who have absolutely no immunity, this row knot is 18. So if I have measles right now, 18 of you in this room will walk away and develop it. So that's a highly contagious pathogen. Chickenpox is around 12. COVID actually superseded chickenpox, but did not make it all the way to measles. Now, granted, that the assumption is that you're in a room full of people with no immunity. That is the controversy of COVID. Now we have a lot of people with varying degrees of immunity based off their immune systems, if it's good or if they're on steroids or some biologic agent or immune suppressant. That degree of immunity might wane or change. But measles, I promise you, it is. If you have no titer, you will get infected with it if you're exposed. It is a tough disease. Last time we have seen it here, I believe there are some cases at VCU. Typically when we see cases domestically, it's from travelers who come from overseas, from a different country, and they have contracted it and they start developing the symptoms when they arrive. We had some of the Afghanistani refugees who came down with that at Fort Lee and were managed here in Richmond. They ultimately did fine, but obviously we can't validate someone's vaccine cards in a kind of refugee crisis. Now, I wanted to overview vaccines before I dive into other antiviral therapies. So inactivated vaccines, so killed vaccines is another way of saying that. You brought up polio, a polio vaccine. There was, Dr. Sabin developed the live attenuated vaccine, which actually some people were able to, the virus is attenuated. I mean, it's been defanged a little bit. It's not supposed to cause the ultimate disease, but will expose you to the protein so your immune system can see it and recognize it to be killed. Unfortunately, the live attenuated vaccine has been largely moved away from because it can cause sporadic paralysis or kind of partial disease, not the full paralysis. But our Attorney General, for instance, in Virginia, was famous for having been exposed to this. Sorry. That's right. Great man, by the way. Inactivated vaccine, so you can heat kill some of these pathogens and still transmit a good immunity by exposing them to inactivated vaccines. Now, so the live vector vaccines. So this is kind of the J&J. So I'll drift into the COVID lane really quickly. So the AstraZeneca vaccine and the Johnson & Johnson or Janssen vaccine were these live viral vectors. And so what you do is you take a virus like an adenovirus, which all of you in the room have had adenovirus, and you unpackage it and you put the genetic material that will make you essentially express only a protein, only a teeny subunit, not a whole virus, of the pathogen you're trying to essentially get immunity for. And essentially that, once the cell goes into the host cell and then that virus kind of uncouples and the genetic material comes out, it does not incorporate into your DNA. It does not do that, but it is that messenger RNA transcript, essentially, the email, so to speak, encodes that protein and is taken out to the surface of the cell, and then your immune system gathers that information and says this is foreign. And if it sees it again, it will attack. Now, this is where I think public discourse is really important. The J&J vaccine quickly developed a reputation of there's some side effects, and the vaccine adverse event system was activated, and there seems to be some clot formation and complications of this vaccine that needs to be discussed. Fairly quickly, they were able to identify some patients who developed clots, in particular areas that you don't develop clots too often. One of the large veins of the brain. Young people started to develop these clots at very, 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 very infinitesimally small rates. But when you have a young person developing, or quite frankly anybody, if you develop clots in the wrong place, you need to really reconsider the vaccine that you're promoting. And so that's why Johnson & Johnson was taken off as no longer available. It essentially inhibited the fourth factor of your clotting cascade. When you do a trial and you have tens of thousands of people in that trial and there's no safety signal, but then you release for mass vaccine, the FDA, one of the people who sits on the FDA advisory board for vaccines, there's going to be some complications. You hope that they're small. The original trials, the phase 3 trials, didn't show any problems, but that's too small of a number. When you're going to give 17 billion doses to people, there are going to be complications. And I think being forthright and identifying those and developing systems that quickly will identify those complications and pull drugs, that's the name of the game. But doing it efficiently, doing it transparently is I think, one of the most important things and lessons learned. So that was AstraZeneca vaccine. That was the Johnson & Johnson vaccine. Virus-like particles are options, gene-deleted vaccine that's done more in veterinary medicine. This is looking at kind of all different types of vaccines. I've talked to you about live attenuated vaccines, so that's measles, mumps, rubella vaccine. So these are live viruses. The chickenpox vaccine is a live virus that's been attenuated. Again, attenuated means kind of, again, defanged, so to speak. And then subunit vaccines. This is like influenza, our typical seasonal influenza. You're exposed to proteins of this hopefully correct strain that is predicted the year before. Which virus do you think will be circulating in the time for next year? And that's how they look at the circulating virus the year before, and they make a prediction as to what do you think closely will resemble our circulating strains year after. And as you can see, vaccine efficacy, a good year might be 50 to 60% efficacy, meaning 50 to 60% of the time it will prevent you from having to go seek a doctor if you do get ill. That's a successful vaccine. That's how you measure success. So I think that's important to know. 37%, which is I think one of the more recent years, that's not a great match. And so they typically package 3 to 4 strains in a given vaccine with a subunit. They've historically grown them in chicken eggs, and they grow these chicken eggs, and then they have the viral particles through the technology, and they will take the subunits and put it in the vaccine after purification and manufacturing. So there is a large push to transition from these types of vaccines to mRNA vaccines because during that incubation period in a chicken egg, there can be denaturation of the proteins being used. It can change as you incubate them in an egg over certain temperatures and time. And so it can make that efficacy less. That's the theory. So you will see different attempts at making new flu vaccines in the coming years. And then nucleic acid vaccines, which is the mRNA vaccines. I'm going to talk a little bit about that. Highly effective. I think millions of lives saved, particularly in the early parts of the pandemic. I know that's, I will tell you just as a physician, physicians weren't, by and large, there were some ones that got a lot of press, but when I was going around waiting to get vaccinated, as we hear that in the coming weeks there's a vaccine, physicians weren't thinking twice about getting a vaccine. It was uniform. I don't care what political part of the aisle you're going to be on. Physicians were all in. However, I will tell you, you can see countries now disputing about boosters. You have the United Kingdom, who gives these recommendations more target for high-risk groups, whereas the United States is more for kind of one size fits all. I mean, different doses for different age groups. So even the world, even large health departments in different countries kind of dispute this. And I think it's important for people to kind of talk about it. And so one of the big things about this, I think it was highly effective. It was mass produced in a very quick after going through the phases, the phase 1, 2, and 3 and getting FDA approval. It was done in a way that, as you kind of remember, there were no shortcuts. There was a phase 1, 2, and 3 trial. So it wasn't like, oh, we're just going to throw a noodle to the wall and hope it sticks. That was not how this happened. However, there were some side effects. And I will tell you some of the side effects that need to be talked about. I'm sure you guys have heard about them. The myopericarditis entity that is a disease state that by and large was self-limiting. It was a very small segment of individuals. It was particularly 16 to 24-year-old, mostly boys, mostly at the second dose. It was an exceedingly small group of people, but not an insignificant group of people, not something to be brushed off. Something that needs to be studied even more as to why did this happen. I think that they're looking into exactly why. I've conducted a trial with a company looking out exactly why does that happen, and are there ways you can manufacture mRNA vaccine that doesn't have the entire spike protein of the virus? Could you give smaller segments of it with virtually no pathogenicity or reactogenicity? That's the hope. That's what the trial is looking at. So I think that's important to say that there was particularly myopericarditis were some things, and also low platelet counts. That was something in a very small segment of people. But we will cast our attention at these small complications. I think they deserve to be looked at, but we gave over 17 billion doses. People, by and large, did great, handled it very well, and we mitigated the risk, particularly early, of severe disease. So those are the types of vaccines out there. I think particularly this group, I find fascinating because this was being studied for a decade in cancer research too, because you can actually boost the immune system to certain cancer cells, particularly melanoma. This is outside the scope of this talk, but looking at mRNA vaccines against melanoma cells is a fascinating, it's already been deployed, and the outcomes are unbelievable. It has completely revolutionized melanoma care. So how we can harness our own immune system to other cancer cells or other diseases, I think refinement of this platform is ripe for future exploration. Any questions? I think it's important. I let you guys talk here because this is usually the most controversial part of the talk.
One question. A lot of times you say, I took the COVID vaccine and I still got sick, so I'm never going to take it again.
Yeah. Yeah.
I mean, what's your thoughts on?
Yeah, and they did that with influenza too. Yeah, 100%. So the question is, one of the biggest complaints about, I would say vaccines in general, but COVID vaccines was I got sick, I can't afford getting sick, or I maybe got COVID from the vaccine. I've heard that too. Really, getting COVID from the vaccine is impossible because you don't even have the machinery of the actual virus there. The original COVID vaccines actually encoded for the whole spike protein of this giant globe of a virion, and it was the spike protein that was expressed in the cell. So it doesn't necessarily, there's no replication capable virus that can emerge from it. However, when we study vaccines, one of the big columns that we study is reactogenicity, which is how do hosts or how do subjects or patients tolerate that vaccine? Does it elicit kind of a broader inflammatory response? And that's something that vaccines, anybody had the shingles vaccine? Yeah, you took the next day off of work probably, or you thought about it, especially the second dose. Some people had worse time for the first dose. So reactogenicity is real. You typically can treat that with Motrin or Tylenol, so to speak. But that's a common thing. And I've heard more of it with influenza. Every time I get the flu shot, I always get the flu. Again, same thing. You can't get the flu from that. You have to have this. It's just impossible to create influenza. And having had influenza a number of times, usually before exams in medical school, which is poorly timed, it's the worst. I mean, it's 2 weeks of absolute hell. And I'll take the kind of lull that I get. So I think that's important. And telling people honestly, you could feel a little bit low after this. You might even get a fever. And typically drug fevers are high. Sometimes people have 104 temperature after a vaccine. Very rarely, but you still see those. And not all vaccines are the same. And I think that's important. Where I see more reactogenicity is here, the live attenuated viruses, because it's a whole virus.
research and the development of these vaccines, this is ongoing. I mean, it seemed like we were hearing a lot of people say they fast-tracked it, and as you
Yeah.
said, they all went through the trials. But
Yeah.
this is stuff that in medicine is developed and is ongoing, and, you know, they're doing that research now and that preparation for,
Yes.
it's not just okay, we'll pull it out and
100%. We are constantly engaging their ongoing vaccine trials, big pharma, but also small pharma. I mean, I'll just tell you, I was going to get into that with monoclonal antibodies. There are plenty of very small pharmaceutical companies who have a novel idea, who don't have the massive funding, who have a good drug that they're working on and they think it's got great promise because they're a couple incredibly smart PhDs, like this is going to change the world. And usually in those kind of crucibles you find incredible ideas that actually surface and change the world. I mean, I forgot where Jonas Salk was at NYU. You know, he was in New York, and really changed the face of the planet. So I'm hoping that the evil empire isn't. You know, I think public and private partnership is really important, and I think medicines, vaccines, and viral treatment and pandemic preparedness is best done in that context. And we can talk about diagnostic testing too, and like this, I would say the CDC, one of the look backs that I think we might have done better is we wanted to make our own diagnostic test with 3 different primers to diagnose COVID. Meanwhile, the Germans already had one that worked just fine. Maybe we should have just used that. And I think partnership with people who, and then manufacturing massive amounts of tests to spread out. I don't think a federal agency necessarily has the bandwidth to do that in real time when you have a lot of other larger companies that can do that with tons of resources and can get it done. So I think in the midst of a pandemic, there's got to be a public-private partnership.
With COVID, I mean, if your spouse has COVID and you do nothing admirable, you just live your life. I mean, I'm not, if she had it, I mean, I never got it, so I don't know, or I never got sick from it.
Yeah, you got it, but you just had subclinical disease. When they've done sampling of large populations of people, and almost everybody who thought they didn't have it has had it, and it was like 99% of the population has antibodies. That means you've been exposed. So it's probably subclinical disease with no symptoms, though you're exposed. You have a tough immune system. Yeah. But so your question is, what do you do? Yeah.
Am I protected? Did I have it?
Yeah, so that's the question is how long, and this is for further exploration, how long do your antibodies stay after you've had true infection? I think the Israelis had some great trials showing that you had profound immunity for fairly decent, if not longer, amount of time compared to the vaccine. What type of antibodies do you make? You're going to be exposed to not only the spike protein antigen from the vaccine, but a bunch of other different like proteins that are on the actual virus. So I think that is like true native immunity from a true infection is profoundly impactful in your future immunity. Now, not everybody's the same. Some people are on steroids, some people are on cancer treatment, some people have a transplant. And so that prior infection, how much does it inform? We can draw your antibody levels in your blood to see if you have an antibody. But you also have T cells that they're hard to interrogate to say, hey, your memory T cells, they can also respond to infections. And we can't, though people didn't have antibodies, they seem to be doing just fine after they'd gotten a few doses of vaccine. Why is that? Let's just say the immune system is a little bit more complex than just drawing antibody levels. And I think there are T cell memories part of that. So I think bottom line is, I got COVID a few months ago. I'm not rushing to go get a booster. Why? Because I'm going to have protective immunity for some time. How long? That's another question. And I'm an infectious disease doc, and so I'll just put that there. Yeah.
In light of the success treating melanoma, if you were to go 20 years from now, how optimistic are you that this technology can be
So I went to, yeah, sorry, thank you. So how optimistic am I about the future impact of certain cancers with regard to the mRNA platform? I'm very optimistic And I'm going to say I'm more optimistic in the short term for the leukemic kind of not solid tumor cancers. Solid tumors, when you look at when a solid tumor grows and divides, as it grows and divides, the proteins become a little bit more complex, a little bit more diverse, and having a consistent antigen to target, I think, is where they are currently running up against some problems. So your lung cancers, for instance, your breast cancers, tumor markers are hard, and finding antibodies that will not only stick to the target, but will ignite an immune response to kill. That's a whole other thing. That's called neutralizing antibodies. There are antibodies, like if you have HIV, you have HIV antibodies. That's how we make the diagnosis. But those antibodies don't do anything. They don't kill the virus. So I wonder if that's going to be the same for some of the solid tumors. However, the leukemic cells, where you have clones, you have a leukemic cell here, it buds. This one is very similar to this one. Now, that can change as you treat the leukemia. But I will say, I think that in the non-solid tumors, the leukemic cells, that's going to be great. I think even some seminomas and some other tumors. There's just going to be better, there's going to be more impact on certain tumors than others. And I think the ones that we really hope for, I think they're having trouble with that. As of right now, as of 6 months ago when I went to a conference. It's a really good question. And I'm not an oncologist, but that's just, I'm echoing what I've heard.
When you get COVID and you take Paxlovid, some people rebound.
Mm-hmm.
Me, he didn't.
Yeah.
We both had COVID at the same time. And why?
Yeah, I'll repeat the question. It's like why I took Paxlovid post-COVID. Husband and wife both got COVID, both got Paxlovid. He didn't have rebound, she did. Explain why. You still had viral replication at the end of your Paxlovid course. I mean, you were still making it probably in your nasal passage. And despite Paxlovid shutting much of it down, by the time you got to the end of your course and by the time Paxlovid washed out of your system, you still had virus around that was able to carry on the infection to different parts of your respiratory tree, and you still had symptoms, whereas his immune system, whether he had COVID before that or not, that he didn't know about, whether he just had a better kind of equipped immune system for COVID itself. I don't know your medical histories, but there's a lot of complexity here. I will say some people do poorly with COVID who, I don't know, there's a lot going on there. There's your ability to handle oxidative stress. Marathon runners handle COVID seemingly better than others. There's even some studies now looking at your exposure to sunlight and what you make in exposure to sunlight, and this is a Harvard trial, what you make in terms of oxidative kind of chemicals that will kind of allow you to deal with such an infection. Might prepare you for kind of a quicker recovery time. So lots going on in your question, but that's usually what it is. You've had viral replication that's still ongoing at the time you ended Paxlovid, whereas he did not. And that's one of the problems with Paxlovid. There's a lot of rebound, and not to mention it tastes terrible. Yeah. Did you take enough of it? Did you throw up? Like those are real questions. A lot of people.
I knew that.
Yeah.
It was not good.
Yeah.
But I actually tested negative, and then I tested positive. I only had 2 days of negative. I mean, I had COVID for like 7, 8 days.
Yeah.
And I know you can test positive for a little while, and I did. And I tested negative twice, and I thought, oh, what I've done. And then the third day, I felt really bad again.
Yeah.
I'm getting it all over. So I never really got rid of it.
One of the issues with COVID is that it affects the lining of your blood vessels, which means every part of your body. So where your viral replication was ongoing from wherever it emerged again, that's I think why pregnant women do badly with COVID is they have a placenta, and there's a lot of fetal loss there. It can attack the blood vessels there. It can attack obviously lung, brain, the heart. You saw a lot of people develop clots in the heart or clots in the lungs or. And by and large, whenever you inflame and irritate a blood vessel, you have the risk of clotting. And so I'll remember the first few weeks, we would diagnose people with COVID, and then we would call them up, and they would have had a kind of a fatal pulmonary embolism. And these were healthy people. because it attacks blood vessels. As we've gone forward and the community writ large has seen COVID 2, 3, 4 times, and as we've gone through Omicron, which is kind of a much more defanged kind of family of COVID, it's not quite as virulent as it once was. However, tell that to a 95-year-old, who's bedbound. Anything can tip over that person to kind of more morbid disease. Rhinovirus, adenovirus, those can all be kind of really horrible viruses for anybody at that age.
Just one last question. Are you going to talk about when's the best time to get the new COVID vaccine?
I wasn't going to talk about that. Let me get through some of these slides, because I've got a couple more. I've got a few more, and then I can talk about that. Maybe we'll talk about that afterwards.
Okay.
Some of the more, I think, engaging, really, really cool technologies that are coming out. One of the complaints about the current vaccine, and where once you get vaccinated, you'll end the chain of transmission, and you don't need to worry about infecting anyone anymore. Why that didn't age well is because this virus replicates so fast and so efficiently in the posterior oropharynx in those first couple days that transmission could absolutely occur despite vaccination. And so what COVID vaccines don't do is provide a sterilizing immunity, which basically means you need different types of antibodies being produced actually in the nasal passages to stop either binding, or if you do get a mild infection, perhaps stop the shedding. And so there's a lot of interest in intranasal vaccines that will work at the actual location where the virus gets in and gets out. And I think that is the most fascinating thing to me. And so they're actively working on this. You can see this is they're looking at COVID-19 vaccines, but really this could be effective for multiple different respiratory pathogens. And this is a very noisy slide, but at the same time you get the picture. This is when we're dealing with rats, we're dealing with or whatever host you're dealing with in the lab. That is preclinical data. That is before phase 1 when it goes to humans. So there are some out and beyond in human trials now.
I've heard a lot about all the work that's being done on COVID-19 vaccines. What I don't hear about is any work, any substance being done on drugs to kill the COVID-19 when someone had it.
Yeah.
Now, I've experienced people that I've met that have taken drugs like ivermectin, and
Yeah.
it worked. It knocked them right out of it.
Yeah. Well, I mean, I think those are, so Oxford looked at ivermectin. Oh, yes. So the question is, there seems to be a heavy emphasis in the research world on vaccines. And what about other antivirals or maybe other off-the-shelf drugs meant for something else, ivermectin in your case, which is antiparasitic, that does have in vitro activity against COVID if you put it in a saline solution or some type of solution. And that doesn't mean it necessarily has activity in a human body with all the chemical reactions that are going there. Oxford looked into that, which I think was interesting. And at one point during the pandemic, the NIH had said they're not going to dissuade people or encourage people to take ivermectin.
Couldn't buy it at one point.
Right. Because, and I've had, believe it or not, I've had a lot of people take ivermectin because they were convinced that they had a parasitic infection when they actually didn't. And they would go to southern states and actually eat the equine ivermectin. And so ivermectin is fraught with potential uses that is, abuse. And, it actually can be handled at higher quantities and is over the counter if you go to other kind of developing countries. But I will tell you that it's important to take those questions that you have, which is a very valid question. There seems to be some neutralization of COVID with this particular agent. You could say that with a lot of different things. Zinc, azithromycin, magnesium, which was one cocktail, hydroxychloroquine. And, those trials have been done. And when they actually subject them to the scientific method of placebo-controlled trials, they didn't fare well. They didn't do well. And I think that everyone was hopeful for ivermectin because it's very well tolerated. It actually did have some in vitro data that were compelling, but you had to give it at a dose that was just infinitely more than what you would give for antiparasitic dosing. And so that was where ivermectin kind of came into the world and then died off. And when I hear people, oh, I got better on ivermectin, but if say they hadn't got it, would they have gotten better anyway? They can't answer that question. And I was hopeful, but again, I was like, we have to have a caution about that drug and others without subjecting them to a randomized clinical control trial. And I feel like you planted that question just for me because I've got a whole bunch of antivirals I'm going to talk about in a second. Did you have a question? No? Okay. Long-acting antivirals, prophylactic or early treatment options. So one of the things, and as I kind of, as I looked into, I was studying kind of pandemics in the past, with SARS-CoV-1, they had a very interesting, treatment option, which was convalescent plasma. So taking the plasma, I mean, they spin off all the cells, but they take the plasma, the portion of your blood that doesn't have cells in it, but the antibodies and the other proteinaceous material, which likely are mostly, hopefully, some antibodies there. You take that convalescent plasma from a survivor and give it to someone who is infected, actively infected. And they looked at this. This is a observational trial, meaning there's no placebo-controlled randomized clinical trial going on. This is kind of more of a proof of concept. And they noted that people who got convalescent plasma fared better if they got the convalescent plasma before 14 days with SARS-CoV-1 as opposed to later. And what did that mean? So basically what you're saying is you can take antibodies, passive immunity, meaning you're taking antibodies that someone else made or some other, and you give it to someone who isn't going to have the 2 weeks to make these antibodies. We do that, I already mentioned, with varicella immune globulins. We give it if you get bit by a rabid dog or raccoon or something, you get rabies immune globulin. That's a form of passive immunity. Convalescent plasma is more of a blood donation, and you can give it. This was actually tried in 1918. They gave whole blood to. They had to do something with soldiers who were dying, and anecdotally, some people lived. And they're like, wait, giving whole blood. You don't like to give whole blood unless it's matched. Of course, you can get jaundice and quite ill. However, the proof of concept was here. When I was working at the Veterans Hospital during the pandemic early on, I was like, we're not going to be able to wait for the Paxlovids of the world. It's going to take 2 years to get that drug. Vaccines maybe a year and a half. We could get blood donations, and let's try convalescent plasma. It at least has some data. Not great, but it's something. And so they've looked at this in 39 trials. They've done a meta-analysis. Convalescent plasma was not associated with lower 28-day mortality or improved 28-day secondary outcomes, such as hospitalizations. Outpatients had a 26% lower risk of requiring hospital care when compared to those who were given placebo. And so what does that mean? If you give convalescent plasma or antibodies early, prior to tipping over into the inflammatory phases of particularly SARS-CoV, the SARS-CoV-1 and CoV-2 were very, very, very genetically similar. But SARS-CoV-2, if you got convalescent plasma very early, you could potentially turn the table and prevent that inflammatory phase. And so this is how it works. You essentially lace these viruses with a bunch of protective antibodies that you yourself didn't make, but you bring to the table. And that's kind of the backbone of monoclonal antibody therapy. You've actually distilled out the protective antibodies. And you guys heard Regeneron and bamlanivimab, etazivimab, bebtelovimab, all of these antibodies. They were great therapies. They showed a 70 to 80% reduction in relative risk for hospitalization, but only if you gave it early. If you give it late, it doesn't work. And I think that is something that we did at our infusion center. I went to University of Maryland Medical Center for residency. I had some colleagues up there that were starting a monoclonal antibody clinic. We did this here in Richmond. We treated 3,000 patients, just over 3,000 patients. I sent out surveys to all of them. I got 400 returned. And this was during the Alpha, Delta, and Omicron, kind of the first wave of Omicron. We only had 7 rooms. And we saw about, the biggest day was a 62-person day. We saw 6 to 12 patients on average with a staff of 5 people. And what you see on your right-hand side, you can see these are, again, this is not peer-reviewed, and this is not published. This is just internal data that I've collected. We had 34 people in the 65 to 69-year-old age bracket, 54 in the 70-year-olds, 14 in the 80-year-olds, 9 in the so we had 3 in the 90-year-old or above. So of the people who returned the survey, which weren't a ton, of course, but we saw a pretty significant amount of people who didn't need to go to the hospital when you compared it to the right-hand side of the page, where here was your risk of early on in 2020, your risk of hospitalization and death by kind of percentage of people who need death is in orange, hospitalizations in blue, and you could see the older age cohorts, decades, had a substantial more or higher risk of death and hospitalization. Granted, these are very small numbers, but again, this is my way of saying monoclonal antibodies, if we can get one to market in time and the virus doesn't change as this one did, is a reasonable way forward. Again, in the spirit of convalescent plasma. As you can see, I looked at those who were vaccinated, unvaccinated, who had to require vaccine. These are my data here. As you can see, the unvaccinated who got monoclonal antibodies had a low risk of getting hospitalized, and everybody here were high-risk patients. They had some comorbid disease, asthma, COPD, even the younger folks, or else they wouldn't qualify for the monoclonal antibody treatment. However, if they were vaccinated, especially this group, they didn't really need hospitalization. This basically shows, at least in the small group that I saw, if they did get vaccinated before they got monoclonal antibodies, the vaccine had a lot of payload to it. Again, this is a very internal trial that you've got to take with a grain of salt. It's low numbers. And then this is the problem with COVID, is that we have consistent kind of virologic turnover and variants. I didn't know that this was going to happen. I don't know if everybody knew this was going to happen, where we were going to be seeing profound amount of variant generation. And this is the emergence of the Delta strain. You see a good portfolio here in June of 2021, and all of a sudden, boom, Delta took over. And this breaks a concept. Delta was actually one of the worst, most virulent forms of COVID. And it actually, typically everyone thinks, oh, as time moves on, you get less and less virulent. Not with Delta. Delta made it worse. And then Omicron actually made it much less virulent. Seasonal influenza, I want to skip really quick to flu because I think this is really important. We typically have 37 to 43 million influenza-like illnesses, 500,000 ILI-related hospitalizations, 61,000 deaths occurred during the 2018-2019 influenza season. This is a profound amount of deaths that we kind of forget that goes on. And then 2021, our vaccine efficacy was about 37%. So there's a lot of genetic diversity. This is one of these pathogens that keeps me up at night, avian influenza. We typically see avian influenza emerge in the communities I've already told you about, where poultry and particularly pigs and humans interact. And when you do see them and you see someone acquire this, usually in a zoonotic fashion from a host animal to, like for instance, a poultry worker, you could certainly see very high, if it's avian flu, very high mortality rates. And I'm talking over 50% mortality. So this is the one that is, the director, the previous director, Robert Redfield from the CDC, said avian flu is something that keeps him up at night, and same with me. And if we were to have a future pandemic, this is one of the higher likely ones. So I was just in England not long ago, and 2 of the pelicans and birds had been confiscated, taken to wherever they get taken because they tested positive for avian flu. So avian flu and that was right outside Buckingham Palace. So you do see it. Flu goes throughout birds. But however, when it skips to humans, and if it has fitness to transmit downstream of that, which is the question. Usually, if it jumps to humans, it stops with that person. There's very little, if any, human-to-human transmission. Rates of mortality are high. So that's our big fear: is if that skip happened, and then there is an ability to transmit it. Antibody-drug conjugates. This brings up your point. Because these viruses change year to year, it's hard to develop a drug that will target a specific virus because it will change. As it goes around the globe and it goes into different hosts, it will change. And so drugs seemingly won't work every year. However, there's drugs that are similar to Tamiflu that can be tried and put into antibody conjugates where they'll take an antibody and then attach an antiviral to it, meaning like a Tamiflu-like drug that's long-acting. They can make it stay in your system for long periods of time that has more long-acting prophylactic treatment. It's a drug, it's not a vaccine. We had a drug called Evusheld for COVID, which was a long-acting monoclonal antibody that you would get if you were at high risk, and it would stay in your system for 3 months, would provide you protection. That's provided the virus doesn't change. So they have, this is one of your calls to arms, which is we need more antivirals for either prophylactic or potential treatments. And here are all the treatments for flu. These technically should work against avian flu. We know Tamiflu, but there's zanamivir, peramivir. There's baloxavir, which interrupts the viral replication in the nucleus of the cell. So lots of different mechanisms, which is great. I already showed you the case fatality rate of H5N1 was 52%. So, and it's been detected in 23 countries. And here they are. They're all over the world. Hong Kong, South China. First case of this highly pathogenic avian influenza virus is in Scotland, but as we can see, it's really all over the world, and we're not spared. It was detected here in the United States as well. And monkeypox, obviously this is another one that keeps me up at night. And then monkeypox is, I mean, this looks like smallpox. In fact, it's so similar that you likely have some, if you were vaccinated against smallpox, you might have some protective immunity to Mpox. It's obviously sexually transmitted, can be passed kind of in close contact, very close contact. We've had an outbreak last year, a couple years ago actually. I'm going to show you the past from 2022 onward. But we have an ongoing outbreak in Africa that is actually quite on the rise, and its virulence is much worse than 2 years ago. We actually do have a vaccine against it that's made by Bavarian Nordic and called the Jynneos vaccine, and then we have antiviral drugs called TPOXX. That actually, and brincidofovir. So that's one thing that's a bit different. If we do have an outbreak against this, we do have stockpiles of agents that are against it. But you know, this is potentially a sexually transmitted disease. This is or close contact. This is something that could cause problems for sure. Africa right now. Yeah, that's where the current outbreak. No, no. I mean, this is right. This is a human pathogen. Now Mpox, you know, monkeypox was the original name of it. They've changed it to Mpox, and you know, it's a concern for me. As you can see, there's been about 38,000 cases. You can see in the deaths of about 1,500 almost, and then you can see the climb between years. There's an increase in 79% between 23 and 22, and now 160% last year to this year. All right, so I was going to go through some cognitive biases, but I don't want to take a ton more of your time. Cognitive biases are just kind of ways in which you brought up a question of like, I'm going to get the flu if I take this vaccine. That's a big reason why we don't take vaccines. I feel like you're going to get sick because of it. And then that's called a confirmation bias. Another thing is omission bias. I feel better about not taking a vaccine because I feel like doing nothing is safer than doing something. I think that's another, I'm just going to not do anything. For instance, the Guillain-Barré question that you had in the back before we talked. Guillain-Barré is an ascending paralysis that was seen in a 1976 influenza vaccine. You kind of hear about Guillain-Barré as one of the horrible neurologic consequences of a flu vaccine. However, influenza itself causes Guillain-Barré 11 times more. So it's almost, you could safely say that influenza vaccine is protective against Guillain-Barré if you were to protect someone from getting flu. But it is a consequence of vaccine in very rare cases. And I think that, and then another one of the cognitive biases is called available heuristic, where you're like, I can remember back in 1976 that there was Guillain-Barré, so I'm going to not do that because I don't want that Guillain-Barré. But
More susceptible if you're immune compromised?
I wouldn't say so. I think you're more susceptible to the severe forms of influenza in general, but I wouldn't say that, oh, all my transplant patients who get flu get Guillain-Barré. But I don't see that pattern at all. but I see the pneumonia, which is more common. And I see the encephalitis, particularly the more invasive forms, but not so much Guillain-Barré. Guillain-Barré is oftentimes thought of as a kind of a molecular mimicry. It's almost as if your body makes antibodies against the virus, but in so doing, it hits the nerves, the peripheral nerves, and it gives you an ascending paralysis. So it's rare, but we also see it in different viruses, COVID, and other vaccines. So it's a very rare complications of igniting the immune system. And those are some of the things I think we got to consider. So I basically went through pandemics. I went through some of the, what are these vaccines? What are the vaccine preventable illnesses? Vaccines are a good intervention. They are not without side effects. And I think it's important for the medical community to be transparent about when do we see them, what countermeasures do we have against them, and how can we make the science better moving forward? We fortunately have antiviral therapies. We've got short-acting and long-acting antivirals that are under development. And we also have a psychology that we make decisions that sometimes we need to realize, could these be cognitive biases that might help us? They might hurt us too. So with that, I'll kind of close and take some questions.
I wonder if you could speak for a moment to the idea of herd immunity. Your last question.
Yeah.
What can we do to prevent these kinds of illnesses? What strategies do you do? Of course, many of us in this room are old enough to have grandkids, and there are wonderful vectors of disease.
Mm-hmm.
How important as an IU doc do you see if you're developing herd immunity or maintaining herd immunity, whether it be from measles to influenza to COVID?
That's the biggest question right now. I think that so the question is the concept of herd immunity. How do we achieve herd immunity? We've got younger generations, particularly who may be not getting the same vaccine protection as prior generations, particularly the generations who are closest to those diseases. And how can we, and me as an infectious disease doctor, how can I kind of promote and try to get people to get immunity as best possible? Is that generally a good format of your question? Herd immunity it's such a controversial topic in America. Herd immunity is absolutely essential to protecting. You do indeed protect the herd when you are immune. So to a given pathogen, measles being a great case. It's highly, highly infectious. We do have a great intervention in the measles, mumps, rubella vaccine. However, it does take everybody to kind of participate in that. If we don't participate in that, I've already showed you the cases of measles are on the rise. And I think because I think the vaccines that we have seen over COVID, I think it was an incredibly profound scientific breakthrough that really, really saved a ton of lives. But I think some of the policy implications, the policy that were put forth and the implications thereof that have not aged well has kind of violated a social contract, I think. And I think that the scientific community has got to talk about this in greater forums and win that contract back. Because I think that I think as I said, there were some things that didn't age well, and I think the more we have a suspicion of the scientific community as seeing them as all money making, that's their only thing that they're going after. One, I can tell you that's not true. I mean, physicians like myself, we want to save lives and we want to prevent illness to the best of our capacity. However, the more in which we have suspicion between the general public and public health officials and stuff like that, the worse we're going to have. We're going to have worse immunity. We're going to have no herd immunity, or we'll have breaches in that herd immunity, and then we'll suffer the consequences of that. So I think the only way we do that is to not kind of alienate each other, don't live in silos, talk about tough topics in public. And that's what I do. I come out and talk to you guys. These are hard topics to talk about. I've got people from both political aisles. I've been hated by both political aisles throughout COVID, and I just call balls and strikes as I see them. And I think that's my biggest worry If you lose measles, you might lose polio. And then you're going to see some serious downstream implications. And then we'll have to kind of reinvent this wheel of knowing that herd immunity is an important thing to go after. It's hard in America because I think America is, the citizen is sovereign. And for good reason. We came from the monarchies of Europe and the despotism of that. And so we're sovereign. We hold elected officials. We have the right to choose for ourselves how we're going to be champions of our own healthcare. And so herd immunity and kind of a collective, there's an interface there. There's an antipathy that can be there. But I think greater education, keeping total transparency. If a vaccine comes to market and there are complications, let's talk it out and not just minimize it or blow it off. And I think do make really good clinical trials. Sometimes even at the expense of, even if the return on investment isn't as good. Because that social contract so crucial between healthcare providers and patients. I might get in trouble with YouTube on that one, but I don't care. That is what I see as true.
But the new coronavirus that's around so much right now, it's out now. I mean, you can get your shot starting this week at CVS.
Yeah.
Should we wait a month if you want to cover, let's say, in February? We're going to be traveling, with a group of people, or
Yeah.
Is there a better time to get it?
Yeah, that's a great question. I think if you have protective antibodies in your bloodstream at the time of your exposure, that is a great time. If you're going to have to be exposed, that is when you're going to be peak protection. Antibodies do fall off in general 2 months after.
Is the day you get it? Or?
No, you typically make antibodies, I would say 1 to 2 weeks later, probably 2 weeks later. I would say, and this is how I counsel people about when do I get my influenza vaccine. I try to say get it as close to the influenza season as possible. Now, I said that in 2008, and then in August of 2009, we had swine flu. That came about 4 months early. So I can be wrong, of course. But we can give our best estimate. So I would say if I'm going to go if I am a high-risk individual, I think it's a low-risk situation for you to get a COVID vaccine. And I think, yeah.
I'm wondering when I'm definitely thinking.
Yeah, I think COVID is more or less a winter virus, but we do see summer spikes. And I think you're going to go through a respiratory season. Why? And I think a lot of people thought, oh my gosh, those New Yorkers or those Floridian, it's very much about it. When do you aggregate with people? When it's 150 degrees outside in Florida, people hover around an air conditioning unit and they get COVID and they spread diseases. When it's 0 degrees in New York City, everyone's going to be by their heater and they're all going to be aggregated and it's going to spread. And so I think that's why you see this variation. And I think we are not good about making this political. I think it's when you are exposed to people who spread it. So I would say amidst the season, the respiratory virus season, which is COVID, RSV usually comes before flu in the late fall, and the flu usually comes in December, maybe January, and stays till March. So I would say somewhere in the October, November, if you wanted to get your vaccines, I think that's a reasonable time.
Not September.
I don't think you're getting, but I say that, and then if you miss your opportunity to get a vaccine, you're like, oh, I don't have time for it, and it's December, then I've done you a disservice. So when I was more doing an epidemiologic role, I'd say don't miss an opportunity to vaccinate. So if you have the opportunity to get it and the vaccines are available, do it. However, in general, if we're going to talk scientifically, I want antibodies in my bloodstream that are detectable. You're not going to go out and measure those antibodies, but I know that probably 2 months you're going to have 2 to maybe 3 months of antibodies after a vaccine. And again, you still might have immunity that's not measurable that your T cell bring to the table.
So if you've had COVID, say in the last month or so, do you wait that 90 days before you take the vaccine?
Yeah, that was a hot topic. Yeah, sorry, yeah. Say you've had COVID in the past month. How long should I wait before getting a vaccine? I've told people 2 months. If you're I think that's reasonable. It could be a lot longer than that. You might have protective immunity for a year. I don't know. I think that depends on you as an individual and your health conditions and how fit are you, and do you have any heart disease, do you have any lung disease, stuff like that. But I would say in general, I'd say wait a couple months.
Okay,
Yes, ma'am.
Tamiflu. There appears almost every flu season, the last few years, we've had no Tamiflu. You're going to be waiting weeks for it to come.
Yeah.
Why is that an issue if the flu season comes along?
That's a good question. That's yeah. So why is it that we're running out of Tamiflu kind of inventory in different pharmacies? I personally haven't had people say I can't get it, and we trial a bunch of different pharmacies, but I know that it does go on shortage. I think I don't know if they're stockpiling because you really need a prescription. Yeah, you need a prescription, so it's hard to stockpile as a patient. I know that there are national reserves for it if we were to go into a situation that would involve avian flu or something like that. Yeah, that's a logistical question that comes from the manufacturers. I don't really know.
One more.
Yeah.
Long-term COVID. What are you seeing? I mean, as infectious disease, you're following these patients, right?
We're not, because by and large the virus has come and gone, and you're dealing with kind of.
So the long-term respiratory.
Yeah, I mean, by and large, when we were seeing that, there was no residual pneumonia left, but it was more the kind of increased fatigue, headache, just can't get out of bed, depression, yeah, they're like really bad dyspnea on exertion, just like shortness of breath, very, very poor exertional tolerance. And I would say, by and large, there's no antiviral that I'm going to give you at that point because there's no detectable virus. So we would swab them and they'd be negative. So it really landed in a multi-specialty clinic involving pulmonologists, even psychiatrists, even physical therapists, like a multidisciplinary team that could care for all of that. Now, what I do here when the community the medical community was investigating it, COVID, especially early on, did trip people over into a kind of a chronic inflammatory condition where we would see high levels of inflammatory markers upwards of 8 months after the original infection, which is different than most things. And perhaps it has something to do with the fact that it hits your vasculature, which is involving every organ of your body. And it is one of these pathogens that has that unique feature to it. But I will say there are some similarities between people who have, like as far as complaints about the somatic complaints, chronic Lyme, chronic Epstein-Barr, chronic is. I think those are kind of hard to understand illnesses or syndromes, and it's kind of a hit and run phenomena where the system has been challenged and the recovery is protracted, and why that is and what to do about it is still kind of a mystery.
A little personal thing. I had sepsis earlier, and I had an infectious disease doctor that went through that. I don't know that. Yeah, is it tripped by a virus, or what puts that in motion?
Yeah, so it's usually a pathogen. Yeah, so you'd think I'd understand this by now, but I don't. So the question is, I had sepsis, and what trips sepsis? What is sepsis? And sepsis is a general term of you've got an infection that has now become not a localized infection, but a systemic one. And so you can have a sepsis syndrome. It's generally thought of in the bacterial world, where a bacteria has gotten past your defenses and is now in a sterile compartment, like a bloodstream. And now it has access to all of your whole body, and your alarm system, your inflammatory markers are going through the roof. And as you do that, especially if you go into the septic shock portion of that disease, which is the later phases, your inflammatory, your body has set off so many alarms that your blood pressure will drop because your blood vessels have kind of become incompetent, so to speak. And so you can develop, and that's your own body responding to a pathogen. So in some ways, it's your own body causing the problem. However, the original insult is some type of infection. So by and large, the most sepsis we typically see is people who have UTIs that have been ignored or have been very kind of accelerated, and the bacteria has gotten into the bladder and extended into the bloodstream. Pneumonia, you have 2 big bags of blood, and then you exchange oxygen there. Bacteria, you get pneumonia, it can go into the bloodstream very readily there. a ruptured gallbladder, ruptured appendix, some type of intra-abdominal catastrophe, where you have spillage from the intestines into the peritoneum, which is the cavity that there should be no bacteria in there. That typically can trigger a sepsis syndrome. So you need antibiotics. It's generally bacterial. However, I would say, I talked to one of my professors when I was a fellow. I saw this person, they came in with a rash and they were hypotensive and tachycardic and looked terrible. They fulfilled all of the criteria of sepsis, but they had measles. So it can be a viral illness too. I told you about influenza back in 1919. You can get a viral infection of the lungs with influenza and then get Staph aureus bacteria or MRSA in the lungs, and then you have now a bacterial pneumonia. So it can be a double hit. And so that's really what it is. And then so you need an intervention. You need the right antibiotic at the right time, as early as possible. You need source control. If you have a big abscess, that's got to go. And you need to get antibiotics into the place where the infection is. So if it's in the brain, you got to give an antibiotic that gets into the brain. If it's in the urine, you got to get an antibiotic into the bladder. Some antibiotics get there, some don't. And so that's infectious disease fellowship. If you want to apply, I'll bring you on board.
A lot of people die of that too.
I mean, most people do die of that. I think that, pneumonia is considered an old man's best friend sometimes, at the end, and that's actually what people die of the most is pneumonia, or a UTI. That's probably the number 1 and 2. Yes?
In your discussion, what I get from it is, I get a COVID vaccine and, like 2 months duration.
If you've had, I was saying, so the question is, if you're going to get a COVID vaccine, when to do it? Is that your question?
Well, just the pragmatist, and let's put it this way.
Yeah.
I can get a COVID vaccine. So, 2 months from now, we'll put me right into the COVID. Yeah, so I'll just get another one. Can I overkill?
There's no recommendation to overkill. I would say, yeah. And I have seen people who came into my clinic who got 10 COVID vaccines. I'm like, what are you doing? Like, this is too much. Because the premise is I want to keep antibodies. It's kind of a pseudoscientific decision. I want to keep antibodies. If it drops off in 2 months, I'm going to get it every 2 months of my life. The drugs were never studied in that way. Though vaccine injury is rare, you do increase your risk of that if you're going to be getting Q2-month vaccines. Again, another thing is just because antibody levels drop to low levels, does it truly mean that you're not have some level of immunity? So I don't recommend any more than what the manufacturing guideline kind of says. And I don't think that there's any study that suggests, I think you should be thoughtful about this, there's no studies suggest that that's the right way of handling it either. It's kind of a theoretic, I need antibodies continuing to stay up constantly. I have not seen that study. And there's a reason why the vaccinologists haven't designed a study to do that either, because there's likely a little bit longer lasting immunity than that. So I'd say no. Yeah.
Here's another coming out.
Okay.
What about vitamin C and
Yeah, so there's a question of vitamin C, high dose vitamin C when you're sick. That's actually been studied at VCU extensively. I don't think that it impacts.
you don't think that is vitamin C and zinc?
I haven't seen a compelling piece of literature that says, they are components. Those are essential parts of an immune response, is those chemicals, so to speak. To think that you are deficient, zinc deficient or vitamin C deficient, where you're immunocompromised, I don't know if that's probably accurate, because a lot of our foods are fortified with a lot of that stuff. And remember, a lot of people take 1,000% of their vitamin C or their daily vitamin C allotment, or like 6,000%. You can be toxic on vitamin and zinc. Vitamin C is not so much. It's water. Yeah. Yeah. I think if you want to take a vitamin, a daily multivitamin, I'm fine with that. I think all of those vitamins are cofactors and also different kind of, I would say cofactors are very important at preventing malignant cells from forming. And I think like vitamin deficiencies and we don't see a lot of that here. We see it more kind of in developing world, but I think a multivitamin is not a bad thing to do. But it's not going to keep COVID away. It's not going to keep flu or RSV away. If you start eating a ton of it during a COVID infection, I have no studies to suggest you will have a shorter course.
No.
Yeah.
I'm just asking
Yeah.
what the bottle recommends.
Yeah, I'm.
Okay, well, more is better because it's not.
As long as you're not taking what's called hypervitaminosis, which I see a decent amount of, is too much. You need your daily, those are micronutrients, not macronutrients, so let's take your daily allotment. Yes, ma'am.
I have a question about masks. So you mentioned that mask separation had to be more than 6 to 8 feet.
Yeah, well,
So,
yeah.
I know there's different viruses out there, but in particular around COVID, is masking in general areas effective or?
They've done a Cochrane review, and they've showed that a lot of the masking protocols outside of a healthcare setting that you saw had little to no effect on the spread. We saw, despite masking protocols, wave after wave after wave. I think, this is my personal thought, and this a little bit derived from my work with tuberculosis patients. If you have tuberculosis, which is an airborne infection, and you're in a hospital and you need to transport that person from here to here, you put a surgical mask on them, and that is proven to be an effective intervention for the person who is sick to actually keep the respiratory kind of, droplets very close to the face. I think that is a thoughtful intervention when you are actively ill. However, if they were all masked in here, if I'm in here for an hour, I promise you all the air outside that mask is inside my mask after an hour of sitting here talking with you. So I think that is one of those interventions that hasn't really stood the test of time. It's really, like the gentleman was saying, it's really hard to study aerosol dynamics. But I don't think that some of that will age well. You see some of these older pictures. I've seen pregnant women getting shamed in a grocery store for not wearing her mask, and people being turned in for not wearing a mask in a grocery store as you're doing flybys with huge amounts of air exchanges in a 30-foot ceiling. I don't think that aged well, and I think that there are places where it may provide some benefit, hard to measure. And I would just say the Cochrane review that has come out doesn't support the aggressive measures that we did. But again, a petition for grace. We didn't know a lot in the beginning, and if it was anything like SARS-CoV-1 with a case fatality rate of 10%, that's terrifying. So that's all I'll say. Yeah.
All right.
All right, I gave you my best, guys.
Yeah.
Good. Thank you.
All right, appreciate you very much being here.
Yeah.
Great questions, everybody. I'm sure if you got offline questions, Bo, hang around for a minute and answer any of those. But again, thank you all very much for being here. We appreciate it, and we'll look forward to seeing you at the next one.
Thank you.
Thank you.